Hello, good evening, everybody. Good evening, everybody.
Good evening, Prof, sir.
Okay, thank you so much.
Please hold on a little bit, sir, for the introduction. We are waiting for Professor Priska. He's also
We'll go right
experienced
away. We just go straight into the meeting.
Participants are
Sir,
not.
There are 350 people in.
all right, sir.
Well, evening to you, everybody. I think we are behind time and we need to buy back some lost time. So we are going straight into the meeting. And what we are looking at are these is psychosocial, legal, and ethical considerations in genetic counseling for sickle cell disease. That's what we are looking at this point. As things are, we need to understand that the initial lectures we had earlier was actually a kind of stepping stone, a springboard upon which today's lecture is rested. In other words, we are leveraging on the gains that we have recorded over the past 4 weeks or so to be able to come to this point. And we're gradually rounding off. Of course, you know, tomorrow we'll be finishing this phase of this intervention. So I'll be speaking on psychosocial, legal, and ethical considerations for in genetic counseling for sickle cell disease. Maybe later on somebody will come over to do the introductory aspect of who is speaking, but my name remains Adebayo Adejumo, a professor from the University of Ibadan. So during this discussion, I'm going to talk about what we mean by ethical issues in sickle cell disease genetic counseling. And of course, I'll also talk about issues relating to legal aspect of what we do, and of course, call to action in terms of what genetic counselors we need to do to be able to maintain the required ethical legal standard when it comes to working with people that are challenged. In this case, we are talking about people living with sickle cell disease or people with the potential of sickle cell disease. So, of course, there's no point retreating in terms of preparing the background information in terms of what sickle cell disease is, in terms of the etiology, signs and symptoms, diagnosis, management, and none of that. All those have been taken care of. But at the same time, it's nice for us to know that sickle cell disease is a hereditary blood disorder, and it's characterized by abnormal hemoglobin production, resulting in chronic anemia. And of course, very many times there could be vaso-occlusive episodes, and this also may be accompanied with some levels of potential organ damage. The lectures in the first few weeks and the first 2 weeks actually expanded on that. So we can pick up the slides to be able to expand on that. But we need to understand that Nigeria bears the highest global burden of sickle cell disease, making genetic counseling essential for managing the disease and reducing its prevalence. In other words, there is a behavioral aspect of the spread of sickle cell disease. There is a psychological aspect of the worsening of the prevalence of sickle cell disease. So it's nice for us to appreciate this and see what we need to do as professionals by offering genetic counseling to ensure that people with the risk of coming down with sickle cell disease, the risk is reduced to as near zero as possible through preventive primary level management by ensuring that the problem doesn't come up in the first instance. So genetic counseling provides individuals and families with information on inheritance patterns and reproductive choices and coping strategies. And we'll look at a couple of some of these issues as we proceed. But various psychosocial and ethical legal issues could complicate the effectiveness of what we need to offer as genetic counselors. And this could impact, especially patients' right to self-rule, which we call autonomy, it could also in one way or the other affect societal attitudes, dispositions, towards not only the person with sickle cell disease, the parents, the family members, and to a larger extent, the community where this patient is from. And this has implication for what we need to do as genetic counselors, because the individual that you are seeing as your client in your clinic, it's just one of the larger members of a community. So what's affecting one member of the community could, by extension, affect other members of the community. And of course, oftentimes, a patient with a potential SCD diagnosis, almost in all instances, will have had heritability guarantee through the parental lines. So we need to do a little more in terms of preventing the transmissibility, the perpetuation of the heritability of the traits that eventually will make one to be susceptible to SCD. But why is it that we are even talking about sickle cell disease genetic counseling in the first instance? And specifically, why are we concerned about ethical, legal, and social issues in sickle cell disease genetic counseling? And there is the publication by Botkin, that's in 2015. And of course, he highlighted that some heritable conditions, for some heritable conditions, genetic counseling, genetic testing specifically, can provide powerfully predictive information about the individual's future health. And this is what makes it the brighter side of what we do. If there's a level of predictability arising from what genetic testing can offer us, then we should be able to leverage on that and to a large extent work on that information to ensure that those characteristics of an individual that could make him susceptible, that could make him to inherit or to transmit or perpetuate traits that could make subsequent generations to have sickle cell disease, will reduce that transmissibility as much as possible. Therefore, professionals, individuals, families, and communities, they have been concerned about the impact of such predictive power on the psychological well-being of those found to be at risk, especially increased risk, as well as concerns about potential stigma and discrimination that could accompany the entire exercise, which we are going to see to a very large extent also as we proceed into this discussion tonight. So, one of the other reasons for which we are concerned with LC issues in SCD genetic counseling, when I say LC, I mean ethical, legal, social, and social implications in sickle cell disease genetic counseling, is that genetic information about one individual provides presumptive information about other blood relatives. In other words, if we have a member of a family, and of course, maybe it's diagnosed to have HBSS, chances are that one could begin to guess that this problem may not reside or be situated within the ambit of that fellow alone. Chances are that other members of the family could also have similar genetic traits. So a diagnosis of HBSS, for example, will have implication not only for that person who came up with that, who was given that, who had that diagnosis, but the implication could be for the family and could be for other members of the community by extension, although with probably lesser risks. The family or kindred nature of genetic information poses ethical, legal, and social challenges for the appropriate management of that information in clinical and research contexts. So that means every bit of what we're going to discuss tonight, we're going to look at it from two perspectives. In other words, there are times when it may be necessary for clinicians to render care, but it may also be, in certain instances, that you may be interested in the research context of sickle cell disease. So whether it's in the clinical sphere, whether in the research context, the need for considering ethical, legal, and social issues is incontrovertible. And that's one of the reasons why we need to talk about a topic like this tonight. So I have a slide here, that's my slide 5, that's a summary of most of the issues that we need to look at tonight. And talking about this, we have specifically psychosocial issues and ethical issues. Talking about psychosocial issues, you have issues related to stigma, issues related to discrimination, emotional and psychological impact, cultural and religious beliefs, as well as socioeconomic barriers. So these are issues that in one way or the other could come up when we begin to consider social issues, psychological issues, when we are talking about genetic counseling for patients with or with the potential for sickle cell disease. Of course, there are other several ethical considerations also, some of which include autonomy and informed consent. How are we going to marshal that within the ambit of someone wanting to say, this is what I want to do with my genetic information, or I don't want to disclose the genetic information to someone else. I have the right to keep my information. But one thing we have to remember in the context of ethics is that where an individual's autonomous power, hence, that is where the right of the larger majority, that's where it begins from. And in that instance, I will invoke the theory of utilitarianism, where utilitarianism in moral ethics is talking about not only looking at your intentions, but being mindful of the potential consequences of your actions. And it doesn't stop there, because what I've defined will just be consequentialism. But we have an extension of consequentialism that we call utilitarianism. In utilitarianism, we are mindful of the greatest good of the greatest number of people. So if an individual has a diagnosis or a genetic test result saying that has HBSS, such an individual, there's an extent to which he can begin to say, I can keep the information to myself and I can make choices the way I want. That transmissibility that resides within will, in one way or the other, will erode his autonomous power to keep that information to himself, because we are mindful of the likely impact on the larger number of members of that society or community. So there will be a kind of clash between autonomous rights and the need for us to consider moral philosophical positions in terms of the welfare of the larger number of people and the implication of the transmissibility of the traits that that individual with, sickle cell disease will have on the larger impact of the larger members of the community. So also there's confidentiality. To what extent can you say you want to keep your information, and who should have access to that information? And of course, we are going to still look at privacy and confidentiality. What we mean by privacy, what we mean by confidentiality, what's the dividing line, what is the meeting point? And at the same time, we need to look at reproductive rights and genetic selection. In this part of the world, very many times, in terms of gender difference, you realize that the extent to which, pardon me to say, females have power to enforce their reproductive rights is not as strong as that of the male gender. And of course, there are other sociocultural religious practices also that could, in one way or the other, impact or impair or impede, a sickle cell person and disease patient's rights to, enforce its reproductive rights. And of course, also when it comes to genetic selection and reproductive rights, very many times they go together. We're going to look at this as we proceed into this discussion. And of course, what about equitable access to genetic counseling, whether in the rural area, whether in the rural community or urban areas? Do we have an assurance that there will be equitability in the access of every member of the society to genetic counseling service? We will look at this as we go. So I'll try to take a further step looking at some of the major issues that I talked about earlier. When it comes to social stigma and social discrimination, people with sickle cell disease often experience social stigma. And this could be because some people could be perceived as being unhealthy. Some people will look at them as sickly. And of course, some people, as a result of that, may isolate them, from the larger society in one way or the other. This could negatively affect their psychological well-being, and of course, the opportunities in life, maybe by so doing and by extension, be reduced drastically. In fact, some communities will associate sickle cell disease with what we call one weakness or the other. They feel that an individual with sickle cell disease, they don't perceive them as a full-blooded human being that has the trait of what it takes to be a complete person. So there's this discrimination. So they perceive them as being weak. So when it comes to allocation of roles in the society, responsibilities in the society, when you are aware that someone has SCD, chances are that some of the roles you give to fairly perceived as, people without SCD, you may not give them such a role. And of course, some people perceive SCD also as bad luck and leading to discrimination in marriage, employment, and education. And until some of these rights are enforced, people will keep discriminating against patients with sickle cell disease. Of course, there could be stigma and social discrimination, as I said. There are social attitudes towards patients with sickle cell disease, and at times the society could be harsh on them. We need to reiterate that. In fact, some of them could face exclusion. Some of them could be bullied. Some of them could be abandoned due to misconceptions about the disease. Of course, you remember about 20 years ago in Nigeria, there's a state in Nigeria we call Oyo State, and within Oyo State, there's Ibadan as the capital. 20 years ago, there was the case of a girl we call Bose Oyo. Because this girl had a genetic abnormality, the parents had to abandon him, somewhere between Akobo and Ashiba Sharon axis. And of course, it was the military governor's wife that eventually took up the case while the radio station announced that the child was abandoned and that rats, ants and flies had just, totally covered that child right in the bush where they are beside the road. So they abandoned the girl by the roadside because they perceive that, this girl, they may not have what it takes in terms of financial stamina to see her through the vicissitudes of life. So people could discriminate. They could discourage other people from seeking genetic counseling due to fear or social rejection. So if you are not too sure that the society would see you, pardon me, as a normal person, many more people will be careful trying to still also go for, SCD genetic counseling. Of course, studies by Homo et al. In 2018 found that stigma and discrimination contribute to the reluctance of affected individuals to disclose their carrier status. And this could reduce the effectiveness of genetic screening program, because if people don't come out, if they don't come for screening, chances are that there could be a perpetuation, a prolongation of such traits in members of a community. So, but apart from this, there could be emotional and psychological impact also. Receiving an SCD diagnosis or learning of one's carrier status can cause considerable emotional distress, no doubt about that. And genetic counseling must incorporate psychological support to help individuals cope with psychological fallouts that may arise from, even an unconfirmed SCD diagnosis. And of course, fear regarding their future health and reproductive decisions. Genetic counselors should focus on helping to alleviate the anxiety that will come with such negative turns in life as a result of, a positive SCD diagnosis. The emotional toll of discovering carrier status also can lead to stress-related disorders and difficulty in making informed decisions about marriage, about reproduction, etc. So, but apart from this, there could also be cultural and religious beliefs, which could be a fallout of the social challenges that someone could face as a result of being diagnosed with SCD. And of course, some of these cultural and religious beliefs could significantly influence attitudes of people towards genetic counseling, okay? And in some communities, genetic counseling before marriage is discouraged because it's perceived as interfering with divine will. And some people will wonder, why are you trying to, explore God's work? It's God that gives, it's God that takes, okay? People with such attitudes, communities where such opinions hold sway, chances are that their disposition, their attitude towards genetic counseling may be poor. So we need to factor that into what we do to encourage people in such communities to break such myths and misconceptions and to access genetic counseling services, because genetic counseling service before marriage is a major mechanism for ensuring that there is a reduction in the transmissibility of that trait. Also further, beliefs in faith-based healing can lead to reluctance in accepting medical advice and genetic counseling recommendations. Some people believe that no matter what, God is able, even if I am diagnosed to be, an AS. I can still marry an AS. God has the capacity to change, the children that we have. God can do it that none of the children will come down with SS. What if the first child that you are raising, AS versus AS, will be just, a sickler? So it's not bad that one should rely on faith. I'm not against faith, but when begin to price such positions over what we've been able to establish in terms of what it takes to do genetic counseling, to go through genetic testing, we should think about that twice before, trying to establish that faith-based positions supersedes, medical advances that we have been able to obtain in our time. So these cultural perspectives, religious perspectives, could pose challenges to healthcare professionals in delivering effective genetic counseling, because they would keep telling you that you are standing on the side of science and that they think that their God can do anything. I'm not saying God cannot do anything anyway. I believe God is able to do anything, but there are certain things that are pretty clear. The Bible specifically also talks about lead us not into temptation, deliver us from evil. So lead us not into temptation also could be don't lead your spouse into temptation. Don't lead your coming generation to temptation by not being conscious of your transmissibility of SCD genetic traits. And for example, by talking about Yorubas or Southwest Nigeria specifically, they have diverse perception of sickle cell disease. Still talking about cultural and religious perspectives when it comes to sickle cell disease. And very many times these are shaped by our cultural beliefs, the level of medical consciousness, and social experiences. Some traditional views associate sickle cell disease with spiritual causes. They believe that it's a kind of spirit that entered into the parents while they were having that child. Or some people could even have denial. They'll believe that, no, it's not me, it's a witch, or it's a wizard, or it's a spirit that changed the genetic property of the zygote. And which may not be so leading to stigma and misconceptions, while modern perspectives emphasize genetic inheritance and medical management. So still talking about cultural and religious beliefs, don't forget we are talking about ethical, legal, social implications of genetic counseling in sickle cell disease. That's the major topic for tonight. Additionally, still talking about culture, because culture has so much impact or role in the whole gamut of genetic counseling services. Culture could sway the entire success to the right or to the left. And so that's why we as professionals need to factor culture into every bit of what we need to do. That's why we're giving it a consideration, cultural considerations. In fact, even within the domain of science, the place of community engagement is also every day being vanguarded as each day dawns. Even if you are doing the best of, randomized clinical trials, if you do not carry the research environment along sufficiently, chances are that they will not buy into your research, they will not buy into your care, and they will not even claim ownership of the process of your research. And of course, that could affect the entire research cycle and could affect the utilization of, research outputs or products or research benefits. In fact, many families that are affected do not receive proper guidance on managing of sickle cell disease. They begin to deny, they begin to extend, extrapolate. This could lead to misinformation and poor disease management. Because if they come for genetic counseling, they are likely going to have so much more information, not only to cope with their challenge, but even to be able to provide techniques or measures or referrals that will make even a patient that has been found to have SCD to have better treatment. And for those who don't have it, to ensure that the risk of transmitting is reduced to as near zero as possible. The only way that can happen is through correct information and through mechanisms of ensuring that diseases are properly managed. Of course, there are initiatives to educate communities, to promote inclusion and reduce stigma, and these are essential for improving social attitudes towards individuals with sickle cell disease. There's a new concept we call the HERE. The HERE means diversity, equity, inclusion, and accessibility. This is very, very important. If people know that they care for them and that their voices will count, chances are that they will access genetic counseling services and information that will be required to live a meaningful life and to ensure that there is no spread of the traits will be, given its pride of place. In fact, in this part of the world, still talking about Southwest Nigeria, some people perceive sickle cell disease as what we call àìsàn fòníkú-fọ̀la-ǹdè or àìsàn owólabí. Let me interpret what we mean by these words that I put into the italics. When you say àìsàn fòníkú-fọ̀la-ǹdè, that means a kind of condition or illness or disease situation that will make one to be alive today and tomorrow, that kind of a person will be down. So that kind of perception is a stereotype, and in one way or the other could belittle, could reduce the status recognition that you give to fellow members of a society, all because it's SCD positive. Okay? And of course, this other one that I said, àìsàn owólabí. Àìsàn owólabí means the kind of disease that will drain your pocket. That's the kind of perception that people have about it. So many of these things are derogatory. They are not complementary. And in one way or the other, they shut people with SCD or potential traits for transmitting FCD. They may shut them off the track of coming out to access genetic service information, including genetics counseling. What about socioeconomic barriers? Financial constraints are inadequate in many societies, and they could lead to access to genetic counseling services. A kind of community that for close to 100 years, we have not been able to tame malaria. We have not been able to surmount, we have not been able to provide vaccination against malaria. How much more of an hemoglobinopathy? Okay? So that is at every level, whether at individual level, whether at community level, whether at country level, financial constraints are so gross and so scary that access to genetic counseling services may not be given its attention for quite some time to come. But now that we are coming out to improve information, and that's one of the reasons on a night like this, we are close to 400 that are online, that are participating in this kind of discussion. So we'll be the carriers of that message to other people to spread the information that people should come out to access genetic counseling services. But what I will want to say is the extent to which we situate genetic counseling services within the ambit of few tertiary healthcare centers is another worry. As much as possible, we should, very, very quickly begin to consider the need to ensure that there is funding and there is training for funding so that we can have, curriculum for training genetic counselors. But it's not this kind of training that we are having over these 4 to 6 weeks that will make you a full-fledged genetic counselor. I want us to know that, because there are still so many aspects of genetic counseling that the curriculum for this training has not covered. So, but there are master's programs and there are other training certification programs with verifiable and testable curricula that people could access to actually become, certified genetic counselors. Of course, we were told there is such facility also in Ghana. Many Nigerians cannot afford genetic testing or counseling, making it difficult to make informed reproductive choices. Of course, even moving from your place of residence to teaching hospitals that could be distant from where you are could also be a limiting factor. Socioeconomic barriers. In addition, rural communities face shortage of trained genetic counselors, further restricting access to these services. Of course, I must also let you know that the best of our health caregivers in terms of well-trained hands, how many of those who were trained in Chicago, those who were trained in Maryland, those who were trained in established centers in Europe, how many of them are practicing in the villages? Okay, and until we take this training to the nooks and crannies of our communities, of rural communities, we may not be able to break even. Addressing these barriers requires government intervention, improved healthcare funding, and decentralized genetic counseling program that is not just focused in a few tertiary institutions. Okay, so advanced therapy such as bone marrow transplantation, which is our main thing, okay, and of course hydroxyurea therapy remain inaccessible to most patients due to high costs. Hydroxyurea therapy has been found to be very, very efficient. Research has shown that it's a potential, game changer to be able to help us to surmount the problem of transmissibility of SCD. But in a country where ordinary dextrosaline is not available in teaching hospitals, where oxygen cylinders are not available, how are we sure that we'll be able to ensure that such services are, spread to the nooks and crannies, rural hospitals? Okay, there's limited access to care. Many patients struggle with affordability. As I told you, even the cost of transportation from their periods of residence to tertiary health centers may reduce accessibility. A minute ago, I was talking about the here, which is diversity, equity, inclusion, accessibility. We must ensure that every other limitations that will not make people to be able to access, genetic counseling services is removed as much as possible. And we must also give them a voice so that their voices also will count. I mean, people with genetic, disorders, especially sickle cell disease in this context. And when some of these issues have not been sufficiently addressed, it could raise the question about equity. Of course, you realize frontline healthcare centers are being located for, people that are in outbrowse areas. Like in Lagos, you have places like Lekki, Ikeja, where, you have state-of-the-art facilities that will give, so many diverse therapies, including, ability to be able to access hydroxyurea therapy for patients with sickle cell disease. So this could raise concerns about healthcare equity. Should it be the senators? Should it be the parliamentarians? Should it be the politicians? Or those who have access to the fund of the larger Commonwealth that will be able to take treatment to go and treat headache in England? Okay, so this raise question is questions about health equity and whether the government has a responsibility to subsidize healthcare treatments. So for socioeconomic barriers, resource allocation is an in thing. In 2004, I've been under the tutelage of Daniel Sansabin. Daniel Sansabin has spoken so well and published extensively on the area of resource allocation. And this lecture may not have, may not have all the time to go the Daniel Sansabin way. But what we know within the context of Ghana and Nigeria is that with that cost of treatment, ethical conditions, emerge about prioritizing sickle cell disease care and other present health issues. And of course, that's been mentioned by Ibumere, that's as early as 2023. Ethical concerns could emerge. Also, ethical considerations around palliative care and pain management often emerge. Of course, we know in vaso-occlusive crisis, very many times the pain becomes so terrible. It's like hell on earth. To what extent are we sure that they are going to have narcotic analgesics or drugs to actually manage such pains at the peak of their pain experience? Okay, and do we have the facilities? Do we have the personnel that will go around to be able to ensure that people at the peak of their challenges could be assessed and cared for as quickly as possible? So as many as sickle cell disease patients struggle with inadequate pain relief, often due to limited access and opioid analgesics that may not be that available, leading to unnecessary suffering. And there are efforts to improve awareness, no doubt about that, and policy frameworks and healthcare practices. These are things that are just being packaged in our time, but we need to do a little more of this to be able to address these challenges that are mentioned. So still talking about legal issues, of course, we also have, the challenge of being able to separate between when we say ethical and legal. So I'll quickly talk about when we say legal, what does it mean? Although a few things could be ethical, but may not be legal. In some communities, in some countries, abortion is legal, but is abortion ethical? Is it moral for you to keep the baby that is still growing in utero? So, but when we say anything is legal, it means it is coded in the country's constitution. There are things that must be done. Whether it agrees with your culture, whether it agrees with your moral, is no, not important at that point in time, because your legality supersedes over ethical consideration. And it means if there is a flouting or a breaching of anything that is legal or within the ambit of the law, many times there are punishments that will go, to deter others from doing such things later on. But when we talk about ethical issues, we are talking about what we ought to do. Okay, it may be legal, but it is not coded as it's found in the Constitution. So even the questions that you may ask tonight, there may be no documentation in terms of any information that is cast on stone that's concerning this is the way you must answer this ethical or moral question. Okay, there's also moral relativity, so you must be mindful of that. And very many times it's nice for us to know that when we talk about ethics, it's appealing to our moral conscience. It's what we ought to do. But some people also have defined ethics as the scientific study of morality. No society believes that you should cheat. No society, believes that you should fornicate or be involved in adultery. Okay. And if you look at even some of the songs like in Nigeria, Ebenezer Obey sang, that is teaching morality. Okay. But even though we know it's not good for you to, hijack your neighbor's wife, but some people still do it. Okay. So at times, a few things could be ethical, but the punishment for ethicality may not be as coded, as written, and specific as in what we find in the law. But that does not still mean that the society does not reprimand people that vowed moral laws or moral standards. I know in certain parts of Igbo land, if any man or any woman is found in adultery, such a person is made to dance through the village, and people will clap on them and sing for them, to make everyone know that this one has done what is morally unacceptable in this environment. That's the technique by which ethical issues could be, addressed in certain conditions and communities. So when we talk about legal issues in genetic counseling, let's look at the context of Nigeria and Ghana. Okay, so in Nigeria, it raises so many legal and ethical issues. They arise as a result of some of the things that I've said. And specifically in Nigeria, there are several states that have gone beyond the level of morality in shaping the manner by which we perceive and handle and relate with issues related to sickle cell disease management. Okay, in Nigeria, Anambra and Kano, these are states in Nigeria. Anambra is in southeast Nigeria, and Kano is in northern Nigeria. Those states in Nigeria, they have been acted in Nigeria for the benefit of people that are not from this part of the world, especially our Ghanaian friends. You need to know that in Nigeria, we have 36 states and we have one federal capital territory. Most of these 36 states at the northern part of the country, we have Kano, and at the southeastern part, you have Anambra. So these states have enacted laws mandating premarital genotype screening to reduce sickle cell disease in incidents. And of course, where these laws aim to protect public health, they raise human rights concerns, particularly around the issue of autonomy, informed consent, and potential discrimination. And that was according to the publication that is found at Ngovo Collective website. And they published that on the website in 2024. And look at the Anambra State 2019 law, for example, that prohibits marriage between individuals with incompatible genotypes. And some people may feel, even though you are appealing to their moral, conscience, but should you say that an AS should not marry an AS? No, somebody could say, it's my autonomous right to choose who I want to marry. But the law is saying you cannot marry who you want. So this could bring a clash between ethics and law. But I have also said, where there is a clash between ethics and law, law supersedes, law takes precedence. So, but it may infringe on personal freedoms and reproductive rights. And of course, now let's cite a few examples in Ghana. In Ghana, ethical debates center on prenatal diagnosis and selective abortion. So you can see how I wish if we had the time, you can download a very well celebrated case in North America. We call that case Dobson versus Dobson. Dobson versus Dobson. You can download that case and read about it. It's a case that tells us two things. Number one, at what point in time do you treat a baby that is still in utero? Do you consider that baby a person? That's the question. And number two, do people that are babies, fetuses, do they have the same rights as humans? Go and read their answer in that publication on Dobson versus Dobson. We have Mama Dobson at the peak of winter was driving. This is the case. I'm just trying to summarize it. And she swerved off the way and she had an accident. But there wasn't anything obvious at that point in time to point to the direction that the baby in utero, because she was pregnant at the time she was driving, was armed. There wasn't any evidence. But while the baby was born, baby Dobson, later in life, he started, growing progressively to manifest some neurological damages. And later on, somebody woke up from somewhere and said because Mama Dobson was careless. In fact, they used the word negligence while she was driving, that the negligence of Mama Dobson was what eventually led to the neurological damage, genetic damage, the neurological damage, of baby Dobson. And of course, that went through the lower court to the level of Supreme Court in Canada. Okay? If you read the case, I won't tell you what the outcome of that judgment is, because today is not a purely ethics class. So these practices challenge the balance between reproductive autonomy and society efforts to reduce disease burden. Nigeria and Ghana face issues of limited public awareness, inconsistent enforcement. In other words, the laws may be there, but to what extent is the enforceability guaranteed? And of course, apart from inconsistent enforcement, what about accessibility to genetic services? If we are saying that people should keep to your law, are there options that people have to ensure that the transmissibility, information sharing, empowerment is done in such a way that people will not come down to still, make decisions that will, in one way or the other, erode what they should know and affect their judgment, moral choices, reproductive choices that may become harmful later in life. And the many more of people with genetic traits that we are producing, the more the likelihood in coming generations that there will be continuous transmission of that condition. So still talking about legal issues in genetic counseling, the lack of a standardized national legal framework in Nigeria leads to fragmented implementation and confusion. So, but efforts like Sickle Cell Gene Africa Network emphasize the need for community engagement, ethical oversight, and patient-centered policies in genetic counseling across Africa. And that was published as early as 2021. Pencil, I guess, is on this panel, and a couple of some of these other authors, Annie and Olayemi, they are numbered as some of the authors also. So, and of course, Professor Ojengbede, our big Oga, our big father in the business, will still come to speak on the issue of community engagement. What is a community? Why should we engage on those things? He will come to speak on them very soon. So we also need to know that sickle cell disease genetic test results may also reveal information regarding risk for disease of other biological members. So there is implication. If you now know that the condition may not only just affect you, because there are certain situations one may have SCD, but may not be diagnosed early, okay? But if your two parents are SSS and the 3 children in the family have come down with SSS, it may be the first person that I will know, that will actually know. In fact, the parents may not know that they are even SS. There's a possibility, although it's rare. Because some people believe that since Yorubas, for example, in Southwest Nigeria, we call Foniku for Lande, that means such children are not sufficiently healthy, and chances are that they may not fulfill their age, that is, they may die midway in life. But of course, because of the improvement in care and knowledge that is available, and interventions and treatments that could in one way or the other potentiate or prolong life, chances are that one may have SCD and still live the life to the fullest. So such people, the risk of transmitting may still be there. So if one member of the family had now come to know that he's having this trait or is having the condition, do you have the legal enforcement requirement to go and tell other members of the family? These are issues that we need to consider. Addressing these legal gaps is essential to ensure that genetic counseling services respect individual rights while promoting informed choices, informed consent issues. So oftentimes there's a lacuna in this. As we proceed, we will look at it. So the question could be, should family members be informed of the test results if you now know that you have this trait or that you actually have SCD? And who should inform the relatives that may be affected? This becomes the legal questions, social-legal questions that may be raised. Should the individual diagnosed with a genetic disorder inform his or her family that may be at risk? Alternatively, should it be the physician who diagnosed the patient inform the family of the disorder and recommend further counseling and testing or other, accessibility to services to improve their health condition? Who is the one to take care of this? Until we begin to legislate and begin to make policies that will help to streamline, some of these issues, we may not be able to have a perfect answer at this point in time. Okay? So there could be real or paternity issues that may be exposed. Okay? People could now know, oh, so every member of the family, my father is AA, my mother is AA, every other 5 members of the family, they are all AA, but you are SS. So where is your SS coming from? It's likely something happened in between. Maybe another person was an elder mama at a point in time. So the 6th person that came down with SCD, other members of the family could start raising paternity questions. And of course, there could be self-blame under such a situation. Maybe if I had guarded myself very well at a point in time, maybe this 6th child wouldn't have come. And of course, there's something we call perceived culpability. In other words, that, oh, it's like I'm culpable for making this happen. There are other issues concerning legal liability, which could be assumed by genetic counselors whose disclosure may influence decisions about childbearing. For example, the risk of socioeconomic discrimination faced by people with known SCD is documented. And of course, there could be other questions such as, now that we have had 2 children, okay, and we are ASAS, and fine enough, the 2 are also ASAS, can we try the 3rd pregnancy? Okay, that becomes the question. And again, when it comes to writing of the will, the question will be, what part of the will should I give to this one that has SCD? When I know that this one may not live beyond 40 or 50 years based on the perception in our communities and in this part of the world, should I therefore entrust my estate into his hands to someone that is perceived to be frequently sick? Again, there could be compensation that this one that is very sick is the one I should take care of. So that becomes a dilemma. So, and in Nigeria, we could have the question, is genetic testing mandatory in Nigeria or Ghana? Is genetic testing mandatory? Well, I want to let us know, genetic counseling is something that should precede genetic testing. But genetic testing, it remains voluntary. Both countries, that is Ghana, Nigeria, they have even launched newborn screening initiatives. And for example, like the CONSA, which is the Consortium of Newborn Screening in Africa. And this is to improve early detection. The more we empower that agency, the more the likelihood of being able to know more about sickle cell disease, the genetic testing, and by extension, genetic counseling. Ghana has announced plans to expand screening nationally, but at the same time, there's no law enforcing mandatory testing. So everybody was still doing what was right in their own eyes. The level of enforceability of some of those laws, remains questionable. So rumors of compulsory DNA testing were recently also debunked in Ghana as hoaxes. That is, there isn't anything saying that you must have DNA testing. So, but upon the whole, participation remains voluntary, but we know that if we step up the game in genetic counseling and this training that we are into, chances are that people could still buy into the project and people could willingly, go for testing or go more for genetic counseling. Don't forget that genetic counseling and genetic testing, they go hand in hand. Where your counseling is good, people could go for testing. Where your counseling is positive, people could buy into the project. Many more people could buy into the project of genetic testing. Sorry, we started a little late. I was rushed through the remaining slides now. No, there are very many other ethical legal questions that may arise Competent adults have the right to choose whether or not to undergo counseling and testing, and before making decisions, people have the right to be informed of the nature of their condition, its prognosis, potential risks and benefits of a proposed test or treatment, and the alternatives to the proposed intervention. And we as healthcare workers may be held liable for not giving enough information. This is where our own, susceptibility, and this is where our own negligence or malpractice could stem from. So we should be very, very careful. But for us to give information, that means we ourselves, we are sufficiently informed. Okay? A half-baked healthcare worker is worse than someone that was not trained at all. So it means for us to become good genetic counselors, we need to have much more information, greater information upon which be able to impact others, be able to share with others. And that you have learned up to a point doesn't mean that you will fold your hands and you will keep learning. Learning is a continuous exercise. Learning continues throughout life. So we should buy into that. So ethically, genetic counseling may directly or indirectly present some risk challenges to the patient and to the family. And of course, some of the risks that could go with it include psychological risk, social risk, economic risk, legal risk, and physical risk. When you talk about psychological risk, for example, knowledge about the deleterious mutations may bring distress, including anxiety, denial, anger, depression, etc. And of course, when one also now gets to know that, oh, he has certain mutations that could be transmissible or that could, in one way or the other, make one to be susceptible, there could be the fear of isolation in the society, fear of ostracization. Okay? If you have the captain of Chelsea football team now and you are playing PSG on, is it tomorrow or Sunday? If we now get to know tonight that you are SCD, you are an SCD patient, chances are that they may not want to entrust that such high-wired game into your hands, thinking that you may not have, enough wherewithal. I'm just citing that as an example anyway. But it means when people know that you are, having traits suggesting that you are SCD, SCD patient, there are many responsibilities, statuses, roles that may not be ascribed to you as a member of a community. So, and it also could challenge previously held beliefs, taboos, and myths, about that person. And of course, it's for some cases, there may be the call for spiritual cleansing, spiritual warfare, ritualistic practices, because somebody has now said, you have AS combination in marriage. Oh, you want to now start fasting and praying the more, and ritualistic practices in terms of maybe binding and losing. I don't know what they do around in your community. And of course, this could affect reproduction and decision making, and of course, utter perception of social status and roles of some of those in that bracket. There could be economic implication. I've already said that the issue of Uniku Volande, that is somebody that is well today, tomorrow is down, may not be sufficiently employable. Insurability also will worsen. The insurance value of someone that has SCD will also jack up compared to someone that has an AA status. And cost of lifelong treatment also may be a challenge economically. And of course, very many times, if an employer gets to know that this is the status of a potential, employee, chances are they may not give such a person, such a job. And of course, physical, although not common. So when we talk about autonomy and informed consent, that becomes an issue in the ambit of genetic counseling. Ideally, genetic counseling should empower individuals to make informed reproductive choices, but in Nigerian society and familiar pressures often influence decision-making, limiting personal autonomy. So some families insist on genetic screening before marriage, potentially coercing individuals into decisions that may not fully understand or agree with, okay? And there are certain situations where someone can say, for one reason or the other, I don't care. Whether I perish, this is someone I love. But before one becomes drunken with love, it's nice for us to share this information so that the individual could be able to have enough information upon which is making decisions that are well informed or rested on sufficient information. Ethical genetic counseling must ensure that patients receive comprehensive information and have the freedom to make choices without being forced. So people should still be allowed to make, because the word autonomy means autonomous, right to self-rule, right to self-governance. So we should still, to a large extent, still allow people to express themselves. But there are questions about confidentiality and privacy when it comes to genetic counseling also, because there could be breaches of cultural norms, because family history, family pedigree, you will need to share that when you go to your genetic counselor, and so much information that not be open to the outside world when you are sharing your background information. When we are taking the family history, becomes known to very many people, especially the person that is taking that history. Disclosing a person's career status without their consent can lead to social exclusion or forced relationship terminations. And there are ethical guidelines which ideally should emphasize the importance of safeguarding private information. And I went ahead to now say confidentiality in SCDGC is maintained through, number one, ensuring that it's informed consent before testing. If I want to mention this informed consent, it means there must be sufficient information. It means the information must be adequate, must be well timed, and the person that you are sharing that information should be competent to be able to understand what you are saying. And of course, there should be freedom upon which that person is making, decisions concerning yes or no, bear premised on the information that you are sharing. And of course, there should be authorization. People like Bishop and Childress, people like in some, SIOMs, they have already published in the area of informed consent concerning what we need to do about this. And SIOM specifically talked about, SIOMS is Council of International Organizations of Medical Sciences. There are several international guidelines that talk about ethical issues, but I'm citing SIOMS in this instance because there's a section in SIOMS that talk about people that are vulnerable, including people with some of these conditions. So look at what SIOMS is saying and how SIOM can guide you in the informed consent process in counseling and pre-testing and sharing of results. Of course, how do you secure information of genetic information? How do you secure it? That's also very, very important. That's very important. And I'm still going to mention one or two techniques by which you could secure information that we have obtained in just such a way that privacy and confidentiality will be measured. Privacy is the extent to which you want to share information peculiar to you with someone else, with authority. That's privacy. But confidentiality is the art of ensuring that that information that we have that belongs to someone else, the extent to which you are making it inaccessible to other people, preventing unwarranted, unsolicited, access to information. So that's what confidentiality focuses on. Of course, but you could limit access of unauthorized people or personnel to such information when you have done your counseling or you have done your pedigree construction. And of course, careful disclosure to family only when ethically justified should be one of the guiding philosophies when it comes to confidentiality in sickle cell disease genetic counseling. So there are techniques by which you could actually, ensure confidentiality. You can score that information that you have obtained now in passworded computers so that no one can have access to that confidential information about the client that has come to you for counseling or that you are still counseling. And you can save such information in the cloud that no one could have access to it. And the essence of saving information also in the cloud is that even if your computer gets stolen, you can still retrieve your information from the cloud. Then you can store information in storage of relevant files in locked up cabinets, that are locked up, that the counselor will be the only one that will have the key to such cabinets. You can also de-anonymize. The name that the person gave to you initially was, Evelyn, but you can change it to Esther, but the code is with you. You anonymize. You remove, the identifier. You can also encrypt certain messages to ensure that nobody will have a right to it. So what about reproductive right and genetic selection? Some leaders may hope for termination of affected pregnancies, sparking debates on morality of personhood. Who is a person? Is a baby if it's a fetus in the first, second, or third trimester, are they persons? Okay. There are people who argue right and left in the domain of philosophy concerning issues related to abortion. But the bottom line or the argument or the most popular position of philosophers concerning the morality of personhood is that a fetus is not a person, because a fetus may not have rights that he or she, as a being in utero, will be able to defend as his own rights. At that point in time, he's not familiar with his own rights. So, and cannot also come up to say, this is my right that you have contravened. And that's the case in the case I asked you to read. Dobson versus Dobson. Because while it got to Supreme Court of Canada, there was a split judgment. There were 7 judges, 3 in favor, 3 against. So it was the lead judge that eventually came up to say, when we get to a situation like this, we need to ask the question, who is the person that is bringing this case to court? Is this person a person? And if it was that the baby Dobson got injured while he was still at about maybe 24 weeks of life or 48 weeks of life, such a baby in utero is not yet a person, and a non-person cannot sue a person. That is the way the Supreme Court of Canada handled that case in that year. So genetic counseling must provide balanced information, ensuring that individuals understand all options without coercion. Equitable access to genetic counseling. I think I talked about some of these things, making sure that we remove bottlenecks and to ensure that every hindrances towards accessing these services are reduced to near zero. And of course, we should strengthen mechanisms to ensure that people have access to, have adequate counseling and support. Well, how does this appeal to principlism? When I say principlism, of course, if I have all the time in the world, I will have taken us through deontology, I will have taken us through Kantianism, I will have taken us through consequentialism, utilitarianism, social contract theory, but each of these theories, even precautionary principle, they all have their inherent weaknesses. None of those positions appear to be ethically infallible. So in the mid-50s, it became apparent that there should be a new Western approach towards, moral considerations when it comes to research and care. And that was what brought principlism. Principlism is four of a kind. In other words, within the ambit of principlism, we have autonomy, we have beneficence, we have non-maleficence, we have justice. So we are saying in beneficence, in autonomy, as it was mentioned by Immanuel Kant, that we should treat people as a means to an end, as an end in themselves, not as a means to an end. And of course, we should respect the values of people. When you're talking about values, you're talking about rights, you're talking about preferences, of people. And of course, when you're considering people, you must ensure that you don't use them for their instrumental value, but for them to be ends in themselves. And of course, still talking about Immanuel Kant's position to autonomy, also talks about that your intentions matter more than the consequences of your action. But how does this apply to present day research and clinical considerations? Basically, it talks about respecting that individual that you are seeing in front of you as a counselee, and apply. This could be applicable in consent seeking, in pre-test counseling and post-test counseling, privacy, confidentiality, and disclosure of test result, etc. So give them the right to make decisions and how far they want to go, and options that are available to them, include them. Beneficence means whatever counseling service that we are rendering should be that which is adding value to the patient that we are counseling. Any counseling activity that is not making the person to be better than what he was before the counseling activity is nullity. So we should have enough information upon which we'll be able to give information upon which patient will be able to make informed quality decisions. And when we do that, we are benefiting. We are acting in a way that will make that life better. Of course, beneficence also could be in form of removal of harm, but that's different from non-maleficence, where non-maleficence is saying, ab initio, above all, do no harm. So whether you're a social worker, whether you're a psychologist, whether you're a physician, whether you're a nurse, whether you're a pharmacist, the sine qua non is above all, do no harm. And of course, this has been on since 336 BC, in the days of Hippocrates. And of course, that's one of the oaths that physician and Hakim nurses also swear to, that in the course of rendering services, they will not harm patients.
Professor Adebayo Adejumo, you have 5 minutes more, sir.
Okay, I will try. So, well. So justice talks about fairness. Fairness talks about treating equals as equals and treating unequals as unequals. Okay? And to everybody, the extent to which they contribute is what you should also factor into what they get. So this affects community engagement, community activities, making sure that you enforce that people will not be cheated, there'll be fair treatment. But let me warn, there's a difference between equality and equity. In equality, we're saying treat everyone the same way, okay? But equity, you are mindful of the nuances and weaknesses and shortfalls and deficiencies in a member of that community. You are taking care of that in such a way that that person can become fairly, be on the same platform with other members of that community, ensuring that the weaknesses are complemented. That's part of equity. But, equality talks about treating everyone across board the same way. So, but it means we, as counselors, we need to be mindful of some of these things that I have here to mention now. I'll just sum this up. I may not even go to the remaining slides, okay? We must be sure to ask ourselves, for you to claim that you're a genetic counselor, or when you are doing genetic counseling, not only for people with sickle cell disease, in any other genetic condition or any other matter for that, are you competent to give that counseling service? Have you been trained? Have you been certified? Are you working under a professional umbrella that guides what you do? Is any professional group certifying you as being competent, able to do what you are doing? And is your scope of practice, rested on your level of competence based on your training and certification? These are questions that must be answered ahead of time. And of course, if you look at APA also means American Psychological Association, there are some of these standards that you find in their website. They also talk about counselor-patient relationship. There's a camaraderie of the counselor that should, in one way or the other, make the counseling activity so pleasant, so enjoyable to the clients. Okay, there's somebody. So we need to ask ourselves, and of course, I quickly want to talk about relationship in this instance, but we have to be mindful. If you are not careful, when you lose control, chances are that emotions may run into your professional care. And of course, some people could slide down so much that they enter into romantic relationships with their clients. But we are saying in this meeting, the answer is no. For as long as you are in a counseling relationship, no sexual relationship, emotions must run into what you do. You cannot also marry that patient, even if you have been told in your church or mosque that that's your wife, until some organizations say 2 years, some countries' legislation say 5 years, some other countries' legislation say as long as 10 years after you have had a relationship with that patient. You can't think of any emotional attachment to that patient, or sexual or love-related relationships. So we must zip up at all times. So how do you also handle information that is coming into your keeping? There are some of the things we need to consider as counselors. And of course, you have to be mindful that what you are doing could be tested within the ambit of malpractice and negligence and standards. Malpractice means your practice is not acceptable to the standard that's expected of you as a professional. But negligence is saying 4 things. Number 1, you are a professional and you have the duty of care. Number 2, in rendering that profession of care, there were aberrations, errors of omission, or errors of commission. And number 3, that the errors of omission or commission has eventually led to a kind of loss, injury, or harm. Okay? And number 4, that there is a causation, association between your error and the hazard or danger that your counselee or patient has been exposed to, for which the patient or counselee is seeking a compensation. Of course, inclusivity. I have to stop at this point in the time. Thank you so much.
Dr. Adiago, over to you. Thank you very much, sir.
Thank you very much, sir, for this very wonderful and very insightful lecture you are giving us tonight. I'm sure many people that have not known some of these things tonight are awed by the way the professor, the distinguished professor of psychology and bioethics, Professor Adebayo Adejumo, presented it. Thank you very much, sir, for this very beautiful presentation tonight.
It's my pleasure. Thank you so much.
Thank you, sir. There are so many questions, so many of them. Many of the issues that have been you know.
So, Dr. Anyango,
15
please, can we take the second presentation so that all
Okay,
questions come after?
I was just saying that
Yes.
there are so many questions, but I've sorted them. Immediately after
Okay.
the next speaker, then we will take the questions. Keep the questions coming as we invite Dr. Akinyemi Ofakunrin, who will be talking about sickle cell disease in pediatrics. Dr. Ofakunrin, please. Thank you very much.
Professor Adebayo Adejumo can stop sharing so that he can be enabled, so that Dr. Ofakunrin can be enabled. Thank you. While he's sharing his slide, let me just say something briefly about him. I apologize for not introducing Professor Adebayo Adejumo. It's because of our time. And once I see Dr. Ofakunrin's slide on, I will stop wherever. And so let me just take one paragraph. Professor Dr. Ofakunrin is a hematologist at Jos University Hospital, and he serves as the research fellows coordinator for the Sickle Pan-African Research Consortium. He has over 15 years of experience in clinical care, teaching and research. He's the youth site lead for the SparkNet and Accelerate projects and oversees care for more than 1,200 sickle cell disease patients. His work focuses on improving sickle cell disease outcomes by expanding access to hydroxyurea and integrating comprehensive care models. He's also a Fogarty and Marish Lodowska-Curie Fellow under the EU-funded ARISE grant. I'm not going to stop it there. Please don't be angry because of time. We are pressed for time. I cannot say all about you, but I know him very well, and I've had the privilege of working with him. He's a very, very, very responsive, very hardworking person. And I personally appreciate the person of Dr. Akinyemi Ofakunrin. Ladies and gentlemen, please join me in welcoming him tonight. Over to you, Dr. Ofakunrin.
All right, thank you, Prof. Ma. I will quickly share my slides now. So I'm trying to work on it as in sharing it. Apologies for that. Prof, why I'm actually trying to share my slide. So maybe some few questions can be taken with Professor Adebayo Adejumo. Please, Ma.
Okay, that's fine. Dr. Anyango, please reverse gear.
Okay, thank you very much for that consideration, Dr. Ofakunrin. As we await his screen to come up, let's take some few questions. Thank you for all those that have been sending in accolades on the last speaker. But let me start with this last question that someone asked. It's not the last, but very important question. In genetic counseling, the rights of a fetus and adults are quite complex and involve ethical, legal, and medical consideration. The specific approach may vary. Oh, okay, sorry, this is not the one I'm actually looking for. Okay, somebody is asking if a laboratory which checks their genotype makes a mistake, and based on that result, they make personal decisions that affect them negatively. Can they sue such laboratory?
Yes.
That's one question.
The answer is yes, because we, as professionals, we are liable for our actions. Although I didn't have time to talk about type 1 or type 2 errors. This often happens, but whether type 1 error, whether type 2 error, we will be liable. So we need to prevent, malpractices, negligent practices. And the way for that to do that is to give more attention to ethical, legal, and social issues. Are you competent? And are you altruistic? Those questions must be asked and answered at all times. Over. Thank you.
Thank you very much, sir. I found the question I was looking for, the very last one that I was looking for. Somebody wants to know if it is advisable to will a property to someone who has sickle cell disease within the family.
It depends
one
on your
of the
preference.
cultural issues.
And I think I attended to that. It depends on the preference. There could be what we call compensatory behavior. In other words, the owner of the estate, the father in the house or the mother, whoever is superintending over the estate, could want to just compensate this child, believing that every other member of the family is not having, no other member of the family has SCD, but because this one has SCD, let me just make him happy or make her happy by bequeathing many more or much more of my property to this one as a compensatory behavior. But this could be rational, and pardon me to use the word rational, by saying, well, since I know that this one may not live the fullness of his or her life, why do I need to trust my entire world into his hands? Okay, my future, my life after life into his hands. So it depends on the disposition of the person in question. But there is no moral, pillar or moral standard that says this is what you must do. I'm not even sure there's a legal perspective to that. It's your ethics that rubs upon your the law at this point in time, in this situation. That is your morality, your consideration. And this is based on all the LC issues that we have talked about. That will affect your knowledge, that will affect your perception, that will affect your attitude, and your attitude will affect your behavior. And your behavior will now translate to your practice of what you discuss in terms of preparing your outline brief with your lawyer when you are developing your will property or will documents rather.
Thank you very much, sir. Is Dr. Ofakunrin ready now? I can't see the screen yet. All right, so let's continue with the question. Thank you very much, sir. Now, these questions ask what happens to a genetic counselor if he or she violates confidentiality.
Will be liable. It's still liability. In fact, it's not only the one that could be liable. The institution within which he or she practices also could be vicariously liable. I was in a class early in the day in the Department of Psychiatry, and we didn't know whether one or two of them are still online here. And I was talking about legal liability. And one of the things I shared with them is that one single liability could make a practitioner's life to end in ruins. One single liability suit. So we should avoid it. That's the way to go. And that's why I also use the word altruism. And while I was concluding my lecture, altruism is a philosophical or psychological tool for you to place yourself on a scale and ask yourself, am I really competent to even counsel this patient? It's not in all instances that you are at your best. And when you are not at your best at times, or in fact, even if you're at your best, there are certain cases you may not be competent to handle. So you may need to refer. So it'd be altruistic to be able to say, I know at this point in time, for reasons A, B, and C, I'm not able to counsel you at this point in time, or we may need to refer you to someone else. Like I cited the example of, erotic love, relationships. So when you know that you are losing your brain, refer that patient straight away. Don't let the patient be under your counseling, sphere.
Thank you, sir. I will take these two questions together because they seem to go together one way or the other. The first one says, sometimes, the first one is talking about stigmatization. The second one too. Let me read the first one. If perchance I feel or have or experience any stigmatization action towards me at my workplace, can I bring legal action against them? That's against the co-workers or whoever is causing or about
the answer is yes. But you must be able to but you must be able to substantiate that there is one person or one organization or a corporate entity that you want to associate with whatever deleterious they did. I'm able to say this was what they did and this was what it cost. All those causation pathway must be established before you think of suing or any litigation issue.
Thank you very much, sir, on that explanation. The second one that is, that's closely related says, people with sickle cell disease are commonly called sicklers.
Benny.
This is even in medical field. Does that have any stigmatization tendencies?
Oh, of course. That's what we call stereotyping and labeling. Okay? And that leads to stigmatization straight away. And that's part of our sociocultural practices that tend to erode, the humanity in a patient with sickle cell disease. It's still somebody like you and I. You don't have 2 legs, you don't have 4 hands, but it's only that the, genotype is what is making him to be predisposed to certain illnesses and diseases. And if there is enough fund or support, this person can still live the life to the fullest. So why stigmatize? Why do you need to, in one way or the other, make the person to lose the status that he or she should enjoy in a society?
Thank you very
Hello.
much, sir.
Okay, yeah.
I don't think Dr. Ofakunrin is ready.
But let the questions keep coming.
Let me ask these 2 questions quickly. Someone wants to know what clinic can adults that have sickle cell disease go to, and is there any association in Nigeria that caters for them?
Oh, we have several associations in Nigeria. I don't know about Ghana, but I guess they also will be in Ghana. So, but in Nigeria we do. And there are many, many opportunities. And through that, they are doing a lot of networking, and it's helping them to access better treatments and better facilities and better support from individuals, for communities, from governments. Okay, did you get that? So
Yes,
there are
sir.
several opportunities. When they come together, chances are that they can, form a more formidable force to be able to demand for their rights and to be able to access treatment the better, the more.
All right, sir. Thank you very much for that answer. Let me take this one from Aaron Apia Obeng. In genetic counseling, the rights of a fetus and adults are quite complex and
Yes.
involve ethical, legal, and medical considerations.
Excellent. That's true.
The specific approach may vary depending on the jurisdiction, medical
Excellent.
condition, and
That's
individual.
very
It's not a question, but it's a submission. I don't know if
I
you have
agree
something to add to
perfectly.
that, sir.
And I've attended to almost, these are some of the things I've also said earlier. It depends on the situation, it depends on the context.
All right, sir. Let me take this one also from Amina Jafar. What ethical concern arises from mandatory genetic counseling before marriage?
Oh, sure. Well, let me just explain that very straight away. Now, many churches, especially in Nigeria, I may not be able to say what happens in the other religions and what happens in Ghana, but I know of many Pentecostal, if not even only Pentecostal churches in Nigeria, that have in their marriage guidelines now, there must be evidence of genetic testing before they even slate you for marriage counseling at all. The two of you, the spouse, the husband, the wife to be, must bring their genetic test results, because that's where counseling begins from. And not only genetic tests, even HIV screening. I know many churches so that insist on some of those tests. And it's until the results are safe, it's until then they can begin to join you as husband and wife. So, and this is becoming, but the question now is, if the pastor says you cannot marry because you are AS, and we now know that treatments are so much advanced, that somebody can have AS and live the life to the fullest. And that someone is AS does not mean that the person will automatically, have 100% chance of raising children with SCD. What if he feels, I don't even care if I raise children with SCD? Must you stop me? That becomes the intersection between law and ethics, morality and law. But the question is, for a society to be able to ensure that the future generation, the chance of having SCD increasing, the prevalence increasing in subsequent generation is reduced to as near zero as possible, we should still go through counseling by persuasion, by sharing with people. And this is where genetic training, genetic counseling must not be a thing that will start when people are getting set for marriage. It should be what we will start right in primary school, before they even get to secondary school, before they think of emotional attachment or relationships in any form. In fact, that should have been ringing in their brains, so that nobody will even tell them before they will know that it's not the way to go. So, but when it's too late, For them to now make a detour, it becomes a problem. And that's one of the reasons why some people, the pastors will still tell them you cannot join them. And they say they don't care. They will leave your church and still wait. Okay? But when it comes to law, the laws are there in Anambra and Kano. But to what extent have we found it printed in any medium that, so people's marriage have been stopped because they contravene sickle cell disease genetic counseling law? The law is there, but how enforceable? It's still also talking about, like in Nigeria and many parts of the world, for you to ride a motorbike, you have to wear a helmet. The laws are there almost in every community, in every society. But look at Nigeria. In how many situations have you seen people riding or driving, Okada and motorbikes for commercial transportation for that matter, and they're wearing helmets? It's like a 3% chance of seeing such on the highway. Over, thank you.
Thank you very much, sir, Prof. And this concern raised by Prof really calls for a lot of innovation or innovative intervention. I hope somebody will take that up among the participants. Let me ask this question, read this question by Olubisi. He said he asked this question last time but not attended to. Is genotype CC among sickle cell disease? Of course, C and C, we know that they were expressed, but I'm sure Dr. Ofakunrin will also talk about
attend to that. Okay.
And the question from Abby, is gene selection a good step to intending couple of AS genotype?
Some people have complained that it is also immoral to talk about gene selection. That is a technique of dehumanizing the potentials in others and their pleasures and personal preferences. So, it means you are pricing other genes above the one you prefer. And people are feeling that that's also immoral. So gene selection, gene editing, they have their moral, attendant moral issues.
Thank you very much, sir. Aaron Apia Obeng has asked another question that is closely related to what Nana Apia Achia also asked. The borders on confidentiality.
Okay.
Aaron says, please, when can confidentiality be broken in genetic counseling? And Nana asked, as a nurse, can you disclose someone's gene type to his or her family members? Prof, sir.
Okay. Yeah. For this, you do not disclose your result to anyone else except the person that came for that test. Is the one that has the power to share with you who and who could have access to his genetic information. Did I make myself clear on that one? So for you to disclose, you still have to let that patient know that by extension, you are thinking of disclosing this to someone else. If he refuses that, you cannot share that information unless you go a step further. In the US, there used to be what we call the HIPAA rule. And while I was at the NIH, there's something we call the certificate of confidentiality. So these are things you as the counselor may invoke to be able to disclose information, especially when you know that specific information could be of harm, not only to that patient, but to the larger number of people in the environment or community. But let me have the first side. Okay, and there's another rider to that question that came before the one I answered.
Yes, that's the
I
question.
guess that question
Somebody
is
asked,
twofold.
as a nurse, can you disclose someone's gene type to his or her family members?
I've answered that one, but there's another rider to that. I guess there was a prelude
please,
to
when
that
can
question.
confidentiality be broken?
Yeah, I've also answered that. Confidentiality can be broken if it has implication for the life, for endangering the life of a larger number of people. So your autonomous right ends there, and the right of the public or the larger number becomes invoked.
Okay,
by
sir.
disclosing.
That's
Yes.
clear.
It's just like someone having a suicidal attempt and says you shouldn't tell anyone that he is having a suicidal attempt. If that patient eventually proceeds to take the life, you as the counselor will be answerable.
That's clear. Thank you, sir. Let me take this one from Oluwaseyi Aina. Although maybe Professor Priska may have something to say to that also. Please, dear esteemed lecturers, I want a clarification about the program. Is it right to say we are SCD educators since we do not have the license to be called genetic counselor?
Well, I leave that to OB and Priska.
So I think the MPIs will answer.
Okay, maybe I
that
can come.
question.
And I'm getting worried about Dr. Ofakunrin being able
I'm
to
also
join.
worried.
He's wrapping up. I hope he'll be able to join. He has prepared, but there's some technical issues going on. But I hope he will be able to join quickly. I want us to finish this tonight because tomorrow is post-test. Tomorrow is post-evaluation. Tomorrow, a lot of housekeeping. Tomorrow is preparation for hands-on. Tomorrow is analysis of pre and post-test to determine who and who goes ahead to participate in phase 2, which is hands-on. And tomorrow is a day to do the knowledge gain analysis, comparing the pre-test score with the post-test score. So a lot is for tomorrow. And that's why we want just one presentation to be taken tomorrow, and the rest will be used for all of this. But if eventually we are not able to take Dr. Ofakunrin's presentation tonight, it means tomorrow is the last day for the virtual, and it may be extended. I don't know for how long, but let's give him the next 2 minutes more and see what happens. His presentation shouldn't be long, and if he's able to navigate through it, that would be excellent. So about the question that you asked, the last person who asked about being called genetic educators and if you cannot be called genetic counselors. If you are able to meet the criterion set for receiving a certificate at the end, the Zoom that we have shows how long you stay when you joined the Zoom. If you have been coming in and doing a pick, touch and go, and you have not really assimilated, internalized, participated actively, all of those things are going to be revealed by Zoom. If you have been missing sessions, the attendance poll is going to tell us that. And the Zoom has a background attendance also that gives us that information. So at the end of tomorrow, when we pull all of those things together, and you have been able to meet the requirement for certification, there's a certificate attached to this course. And that certificate is certificate of completion of a 4-week hybrid virtual training on sickle cell disease genetic counseling. So it is specific regarding the content you have been exposed to, is specific concerning the duration of this course, and whatsoever it is that you want to use it for in your career trajectory, it is applicable and dependent on what the certificate is saying. But everyone who meets the criteria that have been set will definitely.
Prof, maybe you want to change location. We can't hear you again.
At the end, get a certificate, virtual genetic. Oh no, you can't hear me.
We are just hearing
what
now.
About now?
The
okay,
network
so
broke.
Okay, so that is the certificates that we will receive, and not certificates as genetic counselors, because to be a genetic counselor means you are available to undergo a 2-year master's program and genetic counseling course, which means that you have a background in some sciences. You are either a health professional, a nurse, a doctor, a health social worker, a health psychologist, and all of those things. And then you have taken some courses that are prerequisite. And I will invite all of you to please check on genetic counseling courses all over the world, wherever you've seen them. And if you have what it takes, that would be awesome. I hope I've answered that question. But everyone who meets the criteria will get a certificate of participation and completion. Thank you.
Thank you very much, Ma, for throwing much light into who a genetic counselor is actually and what this means to all of us.
Please, can you
While we
find out from
are,
Dr. Ofakunrin?
I don't think so. I've not seen his screen. Or if you can send it to any of the panelists, maybe it can be shared for him. And while we're waiting for that, Irene Sena Dopenyo asked the question, can our hair color determine our status? She says she has heard that carriers have mild brown hair color, and she wants to know how true this is. I think this has to be taken by hematologists and people who are dealing with sickle cell disease every day. I don't know if Prof wants to say something to that.
Yeah, for me, I don't want to be specific, but we leave that to an hematologist to decide to prescribe. That's beyond my purview. But the much I know is that if I got the question right, your hair color or such traits may not be the determinant. It's the structure of your genotype, hemoglobin. That's what we are concerned with. That's what points to the direction of where you stand.
Thank you very much, sir. That should be clear enough from what has been said over the week now. Dr. Isiaka Taiwo Dada also has asked, how can a genetic counselor manage the clients who are so clung to their belief to the extent of disregarding any information about sickle cell disease?
Well, I talked about the need for us to consider peculiarities of personality, culture, in the diet of what we do. And of course, specifically, there are things we also call myths and misconceptions. So each community, each culture have their own myths, have their own misconceptions. So, but it's by continuous engagement with such communities, by sharing, verifiable, testable information, scientific information with such people. It's until then that we can bring forward a superior argument to be able to douse such tensions or to be able to override some of those nuances and misconceptions that might be negative age-long beliefs. So it means our recourse to knowledge, recourse to science will make us to have a superior argument over such positions upon which you can counsel. Remember, in the domain of counseling, you are not directive. You are sharing information with people upon which they will be able to make informed decisions. That's why the issue of counseling goes with informed consent so closely. And of course, talking about informed consent, information element, disclosure element, authorization element are shared in Budjam and Childress, are shared by SIOMS, Council of International Medical Organizations, and many other authorities. The guidelines are there.
Thank you very much, sir. So, Dr. Isiaka Taiwo Dada, please relate with the presentations of last week. Remember that Professor Priska talked about the non-directiveness of genetic counseling.
Yeah,
so
that's
it's
true.
an ongoing thing, but the clients solely have their own choice to make based on detailed information and education that they have.
So I guess that Dr. Ofakunrin is online now. I may have to step out to give him the space.
Thank you very much, sir, for answering all those questions. Thank you for the time that we have had listening to you. Dr. Ofakunrin, sir, you have the floor. Dr. Ofakunrin, we cannot hear you. I hope you are not muted, sir.
Dr. Ofakunrin, please unmute your mic.
Okay, please, can you hear me now?
Yes,
Yes.
yes, you can be heard.
Loud and
Thank
clear.
you.
Okay, apologies. I'm so sorry. I thought it was tomorrow that I was presenting. I didn't know that it was today. So I will be very fast and at the same time still communicate what I intend to pass across. So this evening, I'll be speaking on sickle cell disease in pediatrics and genetic counseling. I know that, before now, we've said so many things about sickle cell disease, which I'm not, and even genetic counseling, which I'm not going to be repeating. So, but the whole essence of this presentation tonight is actually to describe some peculiarities about the presentation of sickle cell disease in children, and also to emphasize the importance of early diagnosis and intervention, then and the role of genetic counseling in pediatric sickle cell disease. So, well, I just want to mention this case study briefly. As in 2 years ago, a mother brought her 2-year-old son to our clinic. He had painful swollen hands and feet. And initially, she thought that it was a spiritual attack, or maybe the child ate something that the child was reacting to. So the child was crying the previous night before the child was brought to the hospital. The fingers were swollen and very painful. And, nobody knew that it was sickle cell disease. So it was after we, because of the presentation, we ran tests and we discovered that it was a sickle cell disease. So the mother was shocked. And prior to that time, they didn't know that they were carriers. And no one had told them about this before. Not that there was any antenatal counseling, not that there was any newborn screening that was done. So I know that all of us were actually very familiar with, what I've just said, that these are things that we see daily. And this is actually pointing to the fact that genetic counseling is very, very important. So now, talking about peculiarities of sickle cell disease in pediatrics population, as you can see from this picture, the first signs that they normally present with, which is one of the earliest signs, is actually the swollen hand and foot that we call dactylitis, as you can see. So I'm actually also trying to use this medium to pass the information to every one of us, so that if you see a child with, a child that was walking before suddenly decide not to step on the floor and was having pain and the leg or the hands appear swollen, so that we should actually have high index of suspicion that we may be dealing with sickle cell disease. Then likewise, anemia is also a common problem in them. It's expected that a child, maybe let's say 1 year, 2-year-old child, if you do a PCV test for them, at least it should be above 30%. So if a child is brought to you maybe for some other reasons, no pain, but you discover that you PCV test, full blood count was carried out, and the PCV happens to be less than 30, I want us from henceforth to have the suspicion that we may be dealing with sickle cell disease, so that picking them early is actually very important. Infection is also another problem that they have, which is a peculiarity in pediatric sickle cell disease, and is the major cause for mortality in them. So things are changing, with more knowledge of penicillin and so on. So then also some other peculiarities that I want to emphasize, I'm not going to waste time because, time had already gone, is that they can also have acute chest syndrome, which is like a form of vaso-occlusive crisis involving the lungs and is a common cause of death in them. Then also for us to know that stroke is actually common in children with sickle cell disease. As a matter of fact, if you talk about stroke, we'll be thinking of adults having hypertension. But if any child should present with symptoms suggestive of stroke, the first thing that should come to our mind is sickle cell disease, because stroke in them is actually 300 times commoner in them compared to the general population. Then they can also have what we call sequestration crisis. I know Dr. Issa actually spoke about this, but we're just bringing it back that these are actually very peculiar to children with sickle cell disease. So now, then the last thing is actually about the impact of sickle cell disease on the growth and development of children generally. This is also a peculiar thing, so that they can actually have some delayed height and weight, a failure to thrive. By the time they are getting to the teenage age, delayed poverty, there could be some neurodevelopmental delay as a result of silent stroke, which may not be obvious. So you discover that some of them may not actually perform well in school, although we know that there are some of them too that are very brilliant. So all this, for instance, you have a patient that is not doing well in school and is a sickle cell patient, then additional support needs to be given. It could be because the child was having silent stroke. Then they may not have enough stamina to do exercise, to actually carry on with some stressful, strenuous exercise and some activities. Then also there's psychosocial impact of sickle cell disease on the children, the teenagers, and the young adults, and also the fact that they miss school as a result of ill health. So all these are peculiarities that affect children with sickle cell disease. So now, what we're saying about this is that with early intervention, all that I've said before can actually be mitigated, such that it's not compulsory that they must come down with acute syndrome, with stroke, with sequestration crisis, and even picking all this earlier, all these initial things earlier, then we can be able to mitigate them. So, and how can this be done? Newborn screening. Professor Inodu spoke about newborn screening. Then there's aspect of penicillin prophylaxis and making sure that they get their required routine immunization and the special immunization, especially the pneumococcal vaccination that is very peculiar to sickle cell disease. Yes, it's being given to the general populace, but sickle cell disease, they are vulnerable to encapsulated organisms causing invasive infection in them that can cause death. So that we make sure that we give them all this support. Nutritional support and growth monitoring is important. Then early hydroxyurea use. This has been said again and again, that the National Institute of Health panel and even the WHO, the American Society of Hematology, about the use of hydroxyurea, that hydroxyurea should be commenced for all sickle cell disease children, should be offered to them from the age of 9 months, irrespective of the severity of the illness. Either they've had crisis before or they've never had crisis, they should be given hydroxyurea, because it's actually the disease modifier that we have. All the other things that we do, folic acid, giving anti-malaria prophylaxis, paludrin, and so on, they are just supportive care. But the disease modifying agent that we have that is affordable to us is hydroxyurea. So it has become a standard of care that even is actually listed now among the routine medication, as in that's the medication by the WHO that's as part of essential drug list, so that all children with sickle cell disease should be offered hydroxyurea and encouraged to continue. Family education and routine follow-up, very important, so that we'll be able to monitor them, educate the parents, and so on. So now, talking about the role of genetic counseling in pediatric context, when and where should the genetic counseling come in? This has been said. I'm not going to overflog it again, so that before conception, and with what even Professor Adejumo said today, long before getting to the time that you want to start dating, we should actually let people know about genetic counseling. It's by this that we can reduce the burden of sickle cell disease. So then again, counseling can come at the point of when we're doing newborn screening, then also beyond that, even after couples they've had children with sickle cell disease, we can still counsel them on family planning and how, as in planning for other siblings. Some other speakers actually mentioned this, the option that they have to have children that will not have sickle cell disease, and so on. So now, in the context of pediatrics, we still want to say that the genetic counseling, what do we do and how does it help? So that making them to understand the inheritance patterns. I'm not going to go deep into this again, Professor Priska Adejumo mentioned this and some other speakers in the previous lectures. So, but it's important that we help the families to understand the child's condition and for them to also know that the condition is not a death sentence and that the condition is not an avenue to say that the child cannot fulfill destiny. No, the child can. There are individuals, doctors, lawyers, engineers that have sickle cell disease. And even outside the country, talking about longevity for them. There's some people that they live very long. You understand? So, and with the level of knowledge that we have and the supportive care, people with sickle cell disease can do well and live long. So all these are important for us to pass across to them so that we actually, as healthcare providers, we have shared decision on this. And if they can follow what we're telling them, things can actually be good. So informed decision making, as we said, we're not forcing them to do anything in terms of genetic counseling. It's just for them to be provided with adequate knowledge so that they can make the decision by themselves. So I'm going to run as in very shortly. I know that we're 3 minutes beyond time. So also in the context of pediatric sickle cell disease, we should be able to manage, emotional support and for the parents especially, and also managing stigma for the parents and especially the sickle cell individuals. So then again, well, I'm going to send this slide that by reading the slide, we'll be able to pick some things that will be very, very important, which I address as tips for addressing parental guilt, fear, and some misconceptions in sickle cell disease. So that it's important that we provide them with clear and compassionate education. Let's be empathetic when we're doing the counseling, when we're caring for them in the clinic, so that because it's actually not easy, but by providing them with clear and compassionate education, then we'll be able to dispel some blame and guilt. Then also, whenever they're having emotional reactions, we should be able to acknowledge and validate that it's actually normal for them to feel the way they could feel and that it's understandable. So that we'll use that opportunity to still provide them with support. Then also to be able to address some myths that is associated, that has been mentioned even today. Then that will empower them with knowledge and skills. Very important. And what are these knowledge and skills that we'll talk about, at least for them to understand the importance of prompt treatment? Sickle cell disease in children with sickle cell disease, they are not the kind of children that you say, oh, the child is having fever, I want to observe the child till tomorrow. Tomorrow may be too late. So that if there's any problem, let them come to the hospital, let it be identified and let them be treated. Then the need for regular checkups should be emphasized. Good nutrition, then the need for them to adhere strictly to their medication. Penicillin, folic acid, hydroxyurea especially. So then also, when also giving them, as in the counseling, the support, we should use life stories, real life stories of those, successful people with sickle cell disease and they are doing well. We use that and we publish, regarding hydroxyurea uptake. Hydroxyurea uptake in Jos University Teaching Hospital is actually significantly high, although we've not got there yet, but, compared to maybe some other facilities. And part of the strategy that we use was actually those that are the hydroxyurea and they are doing well. We made them to be able to actually speak to others so that giving their own life testimony of what is happening to them. And with that, we've been able to get so many on board and they are doing well on the medication. So when we're saying hydroxyurea or whatever, any other thing that we want to pass across to them, we can use real life stories. So then it's important too that we try and engage fathers and extended family. We know that most times it's the mothers, and even at times the father will actually try to even dissolve the marriage or run away from the union because of a child was born with sickle cell disease. So we need to engage them, counsel them too, so that they can understand what is going on, that the problem is not from the woman, it's actually the genotype both shared by them. So, and the blame should not be put on the woman and not on the child. The child is not a witch. Then, and with adequate support, there could be a great future. So then, very important that we offer ongoing psychosocial support for the sickle cell patients, even including the children, the one that is age appropriate, and also support for the parents. So then the importance of continuity of care and collaboration among health workers to be able to deliver appropriately, it's also very pertinent. So in conclusion, I'm so sorry that I rushed the lecture, but I want to believe that I've been able to pass across some important information to the audience. I will share the slides so that by reading the slides, you can pick up more things. So I want to say that pediatric sickle cell disease is not just about symptoms. It's about future that can be shaped if we actually address things early. And with early diagnosis, family-centered care, and effective counseling, which cuts across board, we don't just manage sickle cell disease, we can help families to thrive. Thank you.
Thank you very much, sir, Dr. Ofakunrin, for this extensive exposition on issues, especially the peculiarities of children having sickle cell disease. Thank you so much, sir. Now, some questions are, there are some, will I call them complaints, that your slide is blurry. So please, sir, when you are sending the copy of the slide, help us look into that so people can get to read your slide more clearly. Thank you, sir. Now, there are few questions sent here. Somebody wants to know, sorry, 1 minute. Okay, thank you. Someone wants to know if it is ethical to withhold analgesics from a sickle cell anemia patient because they think he or she will become addicted. I'm asking you because it's related to the care, but I know that Professor Adebayo Adejumo will also have something to say to that. Please, sir, can you say something to it?
Okay, thank you very much for that, and apologies for the blood
I'm not sure I got that question. I'm not sure I got that question clearly.
Okay, sir. So I would like the two speakers to say something to this. The question is it ethical to withhold analgesics from a sickle cell anemia patient? Because we, healthcare professionals, may think that such patients may become addicted.
All right. So can I take the clinical aspect still related to it? Then Prof, let's really take the ethical aspect. So, as in, well, I would say outrightly that is unethical, but Prof will expatiate on that. So the clinical aspect, as in, according to the recommendation, the current recommendation regarding pain treatment in sickle cell disease, the pain that sickle cell patients have is actually very real, and it has been described and likened to the pain, labor pain that is worse than labor pain. And don't forget that labor pain is just maybe for some hours or maximum days in prolonged pregnancy, but this one is something that they have continuously. So the pain in them is real. So, and it's being said that talking about measuring pain is actually, pain is a bit subjective. So, but despite that it being subjective, whatever sickle cell patients should tell you that this is the level of pain that I have, it is required of us to believe it like that and treat it as such. So that's number one, because the pain is actually real. So that if they tell you that, oh, my pain is 9/10, meaning that it's very severe, then we'll treat based on that severity. And the medication should also be given round the clock when we're treating. Round the clock means that if you prescribe a certain medication, let's say, for instance, you want to give pentazocine, and you say the pentazocine should be taken every 6 hours. So once is that 6 hours, you must give the medication. Either the patient is having pain at that point or not having pain. You know what people tend to do is to give it PRN, meaning that when the pain is there, that's when they want to give. It's been found that with that, all the nerve fibers are already stimulated, the pain will be so severe. But if you do it round the clock, then you'll be able to control the pain faster and they feel better. So we should not withhold pain medication from sickle cell disease based on our assumption that they are dependent. And if we find out that they are actually getting dependent, then we can find a way around that by introducing some other alternative analgesic that they will not be dependent on. So over to Prof for the ethical aspects of that. Over to you, sir.
Okay, yeah, I didn't seem to hear the question as presented by Dr. Anyagu clearly. I wouldn't know whether I also get a moment.
Can I read the question again, sir?
Excellent, please.
Thank you, sir. The question is from Rosanna Oluwafemi, and it says, is it ethical to withhold analgesics from a sickle cell anemia patient? Because she used you, but the you is referring to healthcare workers. Think that this patient may become addicted to the analgesic.
I think Dr. Ofakunrin already answered that question. But I would just need to strike that for as long as that drug was prescribed by a physician, it's our duty as psychologists anyway, number one, to watch out for signs of addiction and dependence, okay? And when we're able to substantiate that there is dependence, there are three things that work together. There's something we call habituation, dependence, addiction. There's a very, very close gap between habituation and dependence. But habituation means it has become part of you. It's a kind of OCD thing, obsessive and compulsive, dimension. But if it is compulsive, that means you can't do any other thing apart from taking that substance. And it may be injurious now to you. If it becomes injurious to you, then we are within the ambit of habituation. But if that condition, in one way or the other, becomes a thing for which there may be subsequent problems, complication, or implication for other people, source of injury or harm to other people, or harm to yourself and subsequent harm to other people, then you are taking it to the dimension of addiction. So, but as it is the substance or the drug that the physician prescribes that we will need to work with as psychologists and to ensure that the manner by which the drug is taken in terms of timing, adherence, conformity. So this is what concerns us. But like in case of pentazocine, it is not the patient many times that will take it or no, especially if it's injectable. It is still the physician, the nurse that will administer the substance. So what we just do is to encourage that the patient should cooperate and adhere to the timing, the frequency, and we watch out for the signs and symptoms of early signs of pain. And as he has said, whatever the patient recalls as his pain level is what we need to also work with, not necessarily, what you assume that the level of pains could be. Don't say, Shebi, you took the drug about 3 hours ago. You should not be having pains now. Although we could reassure, we could give psychological support, but if the patient says that the pain is still there, that means the patient is still there. Especially in vaso-occlusive crisis, we need to appreciate that one. Okay? You may not be able to predict the extent to which, the complication of the swelling, of the failure of circulation at joints, the retention and C-shaped clogging around the microcirculations, you may not be able to predict that. It's the patient that's able to say all those details. Over, thank you.
Thank you very much, sir. Because of our time, I will ask these two questions on hydroxyurea together? Dr. Ofakunrin, sir.
Sorry,
Someone
Dr.
wants to
Anyago, please,
know.
that is the last question. Dr.
Yes,
Anyago,
ma,
please,
this
our
will be the
time is
last
fast spent.
question. It will be the last question. That's why I'm putting the two of them together. Thank you, ma. The questions are,
last question.
Should hydroxyurea be routinely offered to sickle cell disease patients? And can hydroxyurea be given to children with sickle cell genotype? Thank you.
All right, thank you very much. I'll just answer the question very straightforward. So that's what I was actually saying.
No?
That the current recommendation is that hydroxyurea should be offered to all children with sickle cell disease, starting from the age of 9 months, irrespective of the severity of their illness. When the drug first came, there are actually some stringent criteria. You know, it was started in adults before being used in children. So there are certain criteria that 3 VOCs, 3 acute chest syndrome, you must have stroke, and so on. So, but now the knowledge is increasing, and the current recommendation is that it should be offered to all children, like the way is like a routine drug with sickle cell disease from the age of 9 months. So it's now for them to be able to, okay, I accept or I don't accept, but all should have the opportunity to be privileged to know about the drug and to know whether they want to take it or not. But it's actually a good one that can prevent complications and can lead to a better life.
Thank you very much, sir.
All right, thank you.
On this note, I want to say thank you very much to our two speakers tonight. They are both big fishes, and we thank Professor Adebayo Adejumo so much for coming in early and for taking the floor to throw light into many issues that have disturbed our minds regarding sickle cell disease and genetic counseling. Thank you also to Dr. Ofakunrin, who has done justice to issues relating to sickle cell disease in children. We want to appreciate the two of you so much, and we say God bless you. Let me hand over to Professor Priska Adejumo for what we need to hear before we call it good tonight.
I want to apologize for taking too much of our time tonight. I saw participants leaving because we have short our time, but we didn't start on time because of some logistic issues. I apologize seriously. Please forgive us. Tomorrow's class is the last class for the 4 weeks virtual training, and it's very important that we come in on time and start on time to be able to finish on time. Tomorrow is post-test, and we need to get as many information that we can get from the materials that have been shared, and I wish there's an opportunity to do a revision, but it's not just going to be possible. So let's try to read all the slides that we have and prepare for the post-test. And that post-test and the pre-test and knowledge gain is very important to determine all those benefits that we think are within our context. The benefit that within you is that you can make use of this information and caring for your patients, updating your information, increasing your portfolio, and all of that. But there are certain benefits that we have on our own side, like completion, accrue certificates. But if we get the attendance and we realize that you just pump in and pump out, because like I said, Zoom will report to us how many minutes you stay in when you join and all of that, then you may not be able to get that certificate, which you will not be happy about. So we have agreed to give the token for data. It's also very important that you have attended all the sessions to be qualified for that. And finally, number 3, to be eligible, even if you score very high, we need to make sure that your attendance, you have attended and have participated in all the sessions, and then you have scored high enough to meet the cutoff for those who are going to do the hands-on. Definitely, we cannot take all about 500 participants into any clinic or any ward in any of the centers. So the fewer the number, the better for us, but there must be criteria set to determine who and who will meet that. One of essential of which is making sure that you actually participated fully in all of this put together. Finally, for you to be a person who we consider to have written, if 2-3 proposals are scored the same, then we want to look at whether it belongs to a SparkNet site, and we want to look at your attendance to make sure that you have actually attended this program and the knowledge you are bringing is not from somewhere else, and so on and so forth. So that if there's a tie of proposals or protocols submitted, we may have to use all of these variables to determine finally. So I want to say a very big thank you to everybody, and once again, apologies for lateness. In closing, we are like us to close here and say very good night to everyone. If you have any question, please put it in the chat. I will be there right now as people drop off for us to go and join the briefing. And if there's nothing, please sleep well. Yes, yes.
Prof, shall we be taking a picture tomorrow?
Yes, thank you. Please talk about it.
All right, thank you very much, ma. So for everyone on this virtual platform, please let's be well dressed tomorrow. At a point, we will put on our videos and we will take a virtual picture. So it's very important that we dress well so that we appear nice in the picture. It can be taken any moment within the session. Thank you very much.
Okay, thank you and good night, everyone. Sleep tight and wake up early tomorrow. We are meeting by 7 a.m. in Nigeria and 6 a.m. in Ghana. Thank you.